As you know, it's Heart Month, so we really want to get out there and get the goal is to get everybody the awareness of the signs and symptoms of a heart attack and to make sure that you call 911 for yourself or a loved one if someone should be suspected of having a heart attack. On the average, Montanans wait 4 hours after starting to experience signs and symptoms before calling 911 or going into the hospital. They would like that, of course, to be much sooner, less than 30 minutes. So I'll go ahead and introduce the panel here. First of all, we have Erica Schreiber, who is one of our esteemed nurses in the cardiac rehab program. Next to her, we have Erin Lefevre. She is one of our mid-levels, and she is in the hospital as well as in the clinic. Then we have Dr. Ben Plank, who is one of our cardiac interventionalists. So you could see him in the office or on a table in the cath lab if you had to come visit us to get stented. Next to Dr. Plank is Dr. Sasha Kryev. He is one of our cardiothoracic surgeons. So maybe if you're lucky enough to have open heart or valve, you'd be seeing him. Then we have Dr. Kristen Scott-Tillery. She is also one of our cardiologists and the director of our heart failure program. And then we have Corey Bloom, who is a paramedic with American Medical Response. Okay, we'll start out for Dr. Kryev. Can I get a minimally invasive bypass on my LAD from my Lima?
Check, check, check. There are multiple ways of doing minimally invasive bypasses, and the single artery bypass can be done both by hand minimally invasively and using the robot. So yes, the answer is to that, but unfortunately here at the Billings Clinic we don't quite have that technology yet. I'm hoping to have some of those things by the end of the year, but not quite yet.
Okay. Dr. Scott-Tillery, can you maybe give us what are some of the signs and symptoms that we need to know if we think we're having a heart attack?
Absolutely, and I think this is so important to hear this a million times so that you know. Everyone always thinks about the crushing chest pain, the clutching your chest and falling to the floor. But that's not the only sign or symptom of a heart attack. Oftentimes people do have that kind of chest pain, but what you want to think about are other things that go with it. So typically, the chest pain will radiate to your arm, to your jaw. I've actually had patients that thought they were having a toothache. And oftentimes associated with shortness of breath, sweating, getting sick, nausea, and vomiting. Those are the classic signs, but sometimes you don't get the chest pain, you just get the other symptoms with it.
Okay. Dr. Plank, can you tell us what is a stent?
Sure. So I think before talking about what a stent is, just really briefly talk about the coronary arteries. So if you were to look at the heart that's in your chest, the heart is basically a muscular pump. It pumps blood to the rest of the body. And like any other muscle in your body, it needs to have its own blood supply. The coronary arteries supply blood to the muscle of the heart. Those coronary arteries can, over time, develop blockages. And the blockages is, we call it plaque. It's fat and cholesterol that can build up in the walls of the artery. When that happens, it can cause symptoms like chest pain when you exert yourself, or if it's bad enough, it could cause a heart attack. So what a stent is a little cylindrical, almost spring-like tube, and that goes into that artery, and we expand that stent, which is made out of metal. We expand it with a balloon. It opens up that blockage, and the scaffold itself, or the stent, will help keep that blockage open. So that's basically what a stent is. There are different flavors of stents, but that's the basic stent.
Okay. Corey, maybe you can tell us why someone experiencing symptoms of a heart attack should call 911.
Well, you're going to want to call 911 because, thank you. If you call 911, if you think about it, it's easier and better than driving yourself to the hospital. If you're having the symptoms of a heart attack, we would hate for you to be driving yourself. If you're not feeling well, if you're lightheaded, you could have a syncopal episode or pass out, and that would cause an accident, a delay in care. And people wonder, why they would want to call us. It's because we're also going to start treatment right away as soon as we reach you.
Okay, thank you. Kelly, did you have some other? Oh, sure. Okay.
And I'd like to add something to that, why you call 911. It's because in Montana, in Billings, in Red Lodge, and in our community here, all of our ambulances have the ability to do an EKG. The EKG is the tool that tells us what's going on. Are you having a heart attack? Is this an emergency? Is this something we need to have everybody stand by and ready once you hit the door of the hospital? So what you lose by driving yourself is that early treatment and the early ability for us to know what's going on.
Erin, I was just going to ask, what are some uncommon symptoms that people should be aware of? And maybe...
So kind of goes with Dr. Scott-Tillery's comment earlier about the other symptoms to be aware of, sweating, nausea, vomiting, and just being aware that some patients don't feel chest pain. As she said, I've had some patients tell me that, again, they thought they were having a toothache. I've had patients that have had their right arm hurt, but textbook and what everyone hears is that your left arm's going to hurt. So, they've said, well, it can't be a heart attack because it was the wrong arm. And just being aware that, that crushing chest pain doesn't always have to be the worst symptom that you feel. And sometimes it's just spouses noticing that, they're diaphoretic, they're pale, they don't look well, is kind of the initial symptom, too, to get you to the ER and progresses from there.
Okay. Erica, what can people expect in cardiac rehab, maybe once they've had a stent or open heart surgery? What can I expect?
In cardiac rehab, we typically see patients after they've either had open heart surgery, either bypass or valve surgery, after they've had stents or angioplasties, after they've had, sometimes we get patients with a diagnosis of stable angina. And so we usually see patients about a week to 2 after they are discharged. And so when patients come into cardiac rehab, sometimes they mistakenly think that they're going to come in and we're going to have them do calisthenics or some kind of high-level intensity exercise, and really we start very low. I would like to mention, because it kind of falls with what's been said, is a couple weeks ago I had a patient begin cardiac rehab who was a 63-year-old man who was very healthy, who had just finished working out at the Y. And he went home, and on his way home he started not feeling very well. And when he got home, he just said, if I take a shower, I think I'm going to, whatever's going on, it'll go away. And in the shower, he started to have dry heaves. By this time, he had some achiness in his chest. When he walked out of the shower, he told his wife, he said, if I didn't think I was in such good health, I would think I was having a heart attack. And so he sat and he rested for a while, and then he told his wife, I think we need to go to the emergency room. And so they proceeded to drive to the emergency room. And she looked at him, and she could tell by looking at him that his color wasn't very good and that he was diaphoretic, and she knew that he was having a heart attack. But instead of calling 911, they chose to drive. Later on, when my patient was telling me the story, he said the most frightening part of the whole experience was the drive to the emergency room, because his wife was so upset, and she was crying, she was speeding, they almost ran through a stop sign. And so I would really strongly encourage you to call 911. It's the safest and most efficient way, and it's probably, it's just what you need to do. Okay?
What does diaphoretic mean?
Sweaty.
Oh, my.
Dr. Kraev, if I have a feeling, a false heart rate in my legs or arms, but the heart rate itself beats normal, what could that be?
There's a number of things that could cause that, and some of it depends on, did that start suddenly, did that come, or has that been going on for a while? Some of it could be just that you're more aware of your pulse at different times of the day, like when people go to bed or they lie at night, they're more aware of their heart, and they can kind of feel a pulsation, or they feel the pulsation in their head. and I think something's wrong. But at the end of the day, the things that we're worried about is valvular disease, where you have a problem with any of the valves that are giving you some abnormal pulsations, like aortic valve insufficiency, where the main valve that separates the heart from the body is leaking. And then aneurysms. This aneurysms can pop that way, where you kind of first feel we have something pulsating. One of the aneurysms I recently dealt with, the patient felt it. He said, I have this bulge in my groin that pulsates. And that means he's had a very large aneurysm of his iliac artery there. So that's something to keep in mind as well. And if you're concerned, you just got to get it checked out, And maybe we'll say, that's just you be more aware of your body. But some other things can come up.
Okay, thank you. Dr. Scott-Tillery, can you review new research on long-term cholesterol blocking drugs?
So there's been a new update in the guidelines on cholesterol management, and the long and the short of it is that we are treating more people these days. Cholesterol medicines, we refer to them as statins. So you may know them as lovastatin, simvastatin, atorvastatin, rosuvastatin. Those are the ones we use the most often. And the long and the short of it is we know that these drugs save lives. If you have coronary disease, if you've ever had a heart attack or a stent, we know that putting you on a statin keeps that from getting worse and actually saves you from possibly being back in the cath lab or having to visit Dr. Krayev for a bypass. So the new guidelines really tell us that as physicians we need to be more vigilant and we need to be more mindful of the people that we see that we fail to put on cholesterol medications when it's helpful. And we actually have tools and guidelines that help us do that. And if you've ever had any kind of a heart situation, you need to be on a statin. It doesn't matter so much what your cholesterol numbers are. The benefit derived from the statins is more than just lowering the numbers.
Okay. Corey, why might people wait to call 911 or come into the ER? Why do Montanans wait longer than the national average?
We're a tough bunch.
Yeah.
We are a tough bunch, and there's also the denial. I think that a lot of people, well, I've got the flu. I'm feeling sick to my stomach. I've got the flu. I'm just going to stay home and rest. If I lay down for an hour or two and take a nap, I'm going to be feeling better. And the key is, recognizing the symptoms or that something is going on and calling 911 right away. Time is heart muscle, and the sooner that you are treated, the better the outcome is. It's not just about, getting over a heart attack, but if the longer that you wait, the less the quality of life that you're going to have afterwards. If we can get in there and we can have those interventions, it gives you a better quality of life following having an event.
Okay.
Yeah, I just want to say a couple things about that. So I completely agree with that. And you said time is muscle. When there's a blockage in a coronary artery, especially if it's a complete 100% blockage, it's going to be very painful. And that's that muscle responding to not having enough blood flow. A muscle needs blood flow to survive. So that pain is your heart telling you there's a big problem. And also, from the instant that pain starts, there's going to be some damage to the heart muscle. If the pain persists for longer than 20 or 30 minutes. And I've seen patients that see me in the cath lab that had really bad chest pain that lasted 15 or 16 hours, and they toughed it out, and they're very happy about that and very proud of it. But basically, if you wait long enough, the pain will go away, but that means that part of the heart has been damaged to the point where there, even if you open up the blockage, that area there of that muscle is dead. So it won't hurt anymore, but it will reduce how strong the heart beats, and that can cause heart failure over time, and that can lead to arrhythmias and big problems down the road. So I want to echo that. As soon as you think you might be having a heart attack, get on the phone, call 911. They can check an EKG in the ambulance. If you are having a serious heart attack, they're going to let us know ahead of time, and we can activate our team and be ready to open up that blockage by the time you get to the hospital, rather than having to start that whole process when you get to the hospital. So time is muscle. It's important, and call if you think you might be having symptoms.
We all seem to be too busy, because I had one guy who just had to finish getting the snow off the roof in Columbus. And it wasn't until he passed out, ended up on the ground, he finally got brought in. They said he kept having pain. He just wanted to finish the job, so he went faster.
Aaron, these are a couple signs and symptoms. The first one is do women have back pain in upper back and between shoulder blades as a signal of symptom? And the second is kind of onto that. Can back pain be associated with heart problems?
So yes and yes. So back pain, upper back pain can definitely be associated with chest pain, whether it starts in your chest and radiates to your back, or I've had multiple patients who actually it starts just as a discomfort in their back and then progresses from there. We do know women tend to present differently. On average, they are not your typical crushing chest pain, left arm, and up to the jaw radiation. They tend to present more with the less common symptoms of maybe some nausea, vomiting, just back pain, things like that. So definitely.
Okay, great. Thank you.
And another thing to think about with back pain is the most common disease is still, one of the most common diseases is still aortic stenosis, which is very common in folks who have bicuspid or two valves, two leaflets to their valve as opposed to three, like most of us. About 2% of the population has that. Probably in this room, at least 4 people have that. And the thing that's associated with that is aneurysm. And when aneurysm is getting ready to pop, you get pretty bad pain. So if you have an especially ripping back pain or really bad back pain, that's one of the warning signs that something really bad is going on inside the chest.
Okay. Dr. Scott-Tillery, what can be done for congestive heart failure? Is there anything out there new?
There are a lot of things we can do for congestive heart failure. Medication is the mainstay of what we do, but over the last, I guess decade, we've gotten some amazing things. We now have a certain type of a pacemaker that can pace both ventricles together and resynchronize the heart. And that has really strengthened a lot of people's hearts. They've gone from having an incredibly weak heart to a near normal heart. So that's a wonderful thing. There's another medication that's coming down the pipeline and will be here very shortly that had amazing results in clinical trials. And so we're pretty excited about that and really helping people's ejection fraction or their heart squeeze get stronger. So there's a lot that we can do, which is, it's very hopeful for congestive heart failure.
Erica, I had a heart attack 5 years ago. Should I still be working out?
Yes. I don't, it's, many of you might have seen a couple weeks ago we did a story about a woman who had just turned 99 years old, and she was participating in our cardiac rehab, and her goal was that she just wanted to continue to live independently. And we know that exercise helps strengthen our heart muscle, but the other thing is it just helps you do all those activities of daily living. Run your vacuum cleaner, put your groceries away, get in and out of the bathtub or the shower. And so exercise is beneficial, some form of exercise every day of your life. And, there's even modified exercise for people who are, sedentary in wheelchairs. So yes, exercise is very important.
Dr. Scott-Tillery, how long once an AFib episode starts should you seek medical care? I've heard conflicting answers.
So I think you've heard conflicting answers because there are conflicting opinions. But what I say about atrial fibrillation, which is when the heart is irregular and typically fast, is that if you are uncomfortable, come in. So some people are in atrial fibrillation and they never even know it. They don't have any symptoms. But a lot of people, when they go into AFib, feel terrible. Run down, palpitations, feel like your heart's beating out of your chest. oftentimes described as feeling it beating in your neck. And it's uncomfortable. So come in. We have lots of things we can do to get you out of that rhythm. Or at least, if we don't get you out of the rhythm, we can control the rhythm, slow it down, and make it more comfortable. So if you're in atrial fibrillation and you don't have any symptoms, then you don't have to rush in. But if you feel bad, please come in. We're good at that. We're good at taking care of it.
All right. Dr. Kriev, do you perform CPR in the same way if the person has a pacemaker?
Yes. There's many types of pacemakers out there, and some of them deserve maybe more specific discussion, but the CPR is the same for everybody. And at the end of the day, the goal of CPR is not to give electricity to the heart, but to actually pump the heart, since the heart is not pumping on its own. That's why it's important to have those deep compressions where you're really compressing the heart, then letting it fill, then compressing again, letting it fill, to preserve organ perfusion, to preserve brain perfusion. And effective CPR is the one that can generate a good pulse without the heart actually beating with your own compressions on the chest. And pacemaker or not has nothing to do with that.
Dr. Plank, when do you use pacemakers? When do you implant them?
Yeah, so that's a good question. So pacemakers are typically used, so just the types of devices that will pace the heart, as opposed to the kind that will deliver an electrical shock. The pacemakers are used if the heart rate gets too slow. So sometimes people have heart rates that get too slow, maybe at different times during the day. Sometimes people have disease in the conduction system in the heart. The heart has its own conduction pathways, kind of like natural wiring. And sometimes for different reasons, those wires can become damaged. So a pacemaker will monitor how well the heart's beating on its own, and if the heart gets too slow, the pacemaker will kick in and deliver an impulse that will cause the heart to beat at a normal rate. So the pacemaker will be implanted if a person's heart rate is too low and people are symptomatic with that.
Okay.
That'd be the reason.
Thank you. Let's see. And this kind of goes back to the other question you answered a little bit, Dr. Scott-Tillery. What are the concerns of having an irregular heartbeat?
So the first concern about having an irregular heartbeat is clearly symptoms, if you feel bad with it. But atrial fibrillation is its own animal, and atrial fibrillation carries a stroke risk. And that risk is about 2% per year of being in atrial fibrillation and having a stroke. So this is why I don't want you to ignore it, and I want you to come in, because if you are not being treated with a blood thinner with atrial fibrillation, you're at risk of having a stroke. So what we do is we'll talk with you about your risk. We know what the risk factors are for stroke with atrial fibrillation and decide the best kind of medication to put you on to keep that from happening. But definitely atrial fibrillation carries a stroke risk, and it's a shame to not have the opportunity to treat that and take that risk away.
Aaron, what's better during a heart attack, nitro or a handful of aspirin?
Both.
Yeah, I was going to say, both are what you really need. The nitro works to dilate open the blood vessels, which helps relieve some of the chest pain. As I say, it's a Band-Aid for the problem. It doesn't actually fix anything when you're having a heart attack. The aspirin works as an antiplatelet, and actually, when you come through the ER or get on the ambulance, first thing that they will give you is for baby aspirin to chew because of the benefit. So, both are necessary, I'd say.
Okay.
And I'd just like to follow up on that. So that's absolutely right. They've studied aspirin and nitro in people that are having heart attacks. Nitroglycerin will help relieve chest pain, but it has it makes no difference on outcomes. It's not going to make people live longer or survive that heart attack. It might make you feel better while you're having the heart attack. Whereas in people that are having a heart attack that are only given aspirin, if that were the only treatment they got, it reduces mortality by 20%. So aspirin is very important.
Okay.
But you don't have to take 19 of them like one of my patients
No.
did. Okay. A full strength or 4 baby aspirin is what you need.
Yeah, define handful.
Yeah.
Ask that question.
How big of a hand?
Dr. Plank, what is a heart attack?
Okay, yeah, and kind of talked about this earlier, but basically a heart attack is when, remember those coronary arteries that I was talking about before that supply blood to the heart, which is a muscular pump. When there is a lack of blood flow through one of those arteries, when there's not enough blood reaching that muscle, the muscle of the heart's not going to have enough oxygen, which it gets from the blood, or enough nutrients, which it gets from the blood, and that muscle will start to die. If you were to look at it under a microscope, you'd see those muscle cells start to die. So that's a heart attack, when there's not enough blood flow getting to that portion of the heart. The heart has to do a lot of work. It's beating, hopefully at least 50 or 60 times a minute for all of us, and certainly a lot faster if we're exercising or doing activities. And all that work that the heart does comes at a cost. It uses oxygen, uses nutrients. If it doesn't get those things, the heart's going to die. So when there's a blockage in an artery preventing good blood flow, that's going to cause some damage to the heart. That's a heart attack.
Corey, is there any basic training that I or someone else can take in case I witness a family member or a friend having a heart attack?
There is a lot of training out there. So this weekend, Saturday, is CPR Saturday. It'll be at Metro Park. It's going to be at the arena in the basement. And people will be there whether you want to be certified in CPR or not. There will be people there to help you with that. So I believe that goes until 3:30 or 3 o'clock or 3:30 on Saturday. Also, you can call the hospital if you want CPR training. You can call AMR for CPR training. We have people that are able to help set up classes and teach you that information. You can go on to the American Heart Association at heart.org and have more information about CPR and training and symptoms to be aware of, as well as the Gallatin Heart Rescue. They've been promoting the hands-only CPR because with full CPR, people have been less likely to perform it because of the breathing aspect of it.
Okay, thank you. Dr. Scott-Tillery, how can I tell the difference between a real heart attack and just angina, esophagus pain, or anxiety?
So that's a wonderful question, and the answer is you can't. Okay? So if you're having chest pain and chest discomfort, the only real way to figure out what's going on is to get an EKG and to do some blood work to find out. What I want to really emphasize here is that I have a lot of patients who'll tell me as I'm in the emergency room, standing over them, getting them ready to go to the cath lab, that they had heartburn. And what I tell people is that heartburn's heartburn, and we all know what that is. But if you have heartburn that gets worse when you climb the stairs, or if you have heartburn that gets worse when you're exerting yourself, that's probably not heartburn. That may be heart pain. And a lot of times people will feel their heart pain as heartburn. That's why they call it that. So in truth, in the heat of the moment, there's really not a good way for you to tell. And a lot of people will say, oh, I don't want to go to the emergency room and cause all that trouble, and it's a hassle, and I don't want to bother all the doctors if I'm not having anything going on. But that's what we do, and that's what we signed up for. So it's not a bother. So please come in.
Okay. Dr. Plank, after having a normal EKG, why would my doctor have me take a stress test? Is this necessary?
Yeah, so that's a very good question. So an EKG is basically an electrical fingerprint of the heart, how the heart's functioning, and how well the electricity is going through the heart. Everything in the heart, all the muscle and that natural wiring I was talking about, all of that can conduct electricity. If someone has a heart attack and there is some level of damage to the heart muscle, oftentimes that will show up on an EKG. We can actually see, oh, you've had a heart attack. It looks like you probably had a heart attack in the past. We can see that on the EKG. If somebody's having some chest discomfort when they exert themselves, that doesn't mean they've had a heart attack. That might mean there's a partial blockage in one of those coronary arteries. The stress test will help determine if that's true. That should show up in the stress test. But if there's been no damage in the past, if there's been no heart attack, the EKG will look normal. So someone can have a normal-looking EKG, but still have an artery that has at least a partial blockage. And so, yes, that person should still go ahead and have the stress test, which would hopefully pick that up.
Erica, what lifestyle changes help reduce risk factors for a heart attack?
As most of you know, probably the number one risk factor you have is your family history. And so if you have a family history of heart disease, particularly with members of your family who are relatively young, in their 30s, 40s, and 50s, and have had some diagnosis of heart problems, then that would probably be an indication that you need to be screened. The other risk factor that we can't do anything about is the fact that men tend to have more heart disease until after women go through menopause and then as you age. But then there's all those risk factors like smoking. That's probably the number one risk factor that you would want to do is to stop smoking. You want to be aware of what your blood pressure is and keep your blood pressure. The guidelines for blood pressure have recently changed too. We used to say less than 120/80, but they've become a little bit more liberal with that, and it appears that under 140/80 is probably in the neighborhood of where under that should be where your blood pressure's at. Cholesterol, the guidelines have changed as far as that too, but being aware of the fact if you have elevated triglycerides or elevated bad cholesterol, or even if your good cholesterol is too low. Stress, I tell you, it's hard to imagine that stress can be as hard on a person as it is, but I see patients on a regular basis who have very, very stressful jobs and stressful lives, and I just know, and they do too, that the situations are really harming them. So stress is a major risk factor. And then being sedentary. I think we were made to be active, and so if you have jobs that require you to sit a lot, it's very important that you get out and do some form of activity, even if that's just a daily walk. So those I think I've hit most of those there.
So I'll let you guys kind of decide who wants to talk about statins. When is the best time to take statins to avoid body aches and pain?
I'll
Okay.
pipe in there. So statins get a bad rap. If you Google statins, you'll see some horror stories out there. Aches and pains are very common in everybody. Well, not in everybody, but they're very common for people to have joint pain or muscle aches. If the studies that looked at, do statins actually cause muscle damage that would cause muscle aches and pains? It turns out statin-induced muscle pain is very rare. Less than 1% of people that are on statins truly have a statin reaction that causes muscle pain or weakness. So that's something important to know, because oftentimes people will be on these medications and maybe they have arthritis or maybe they've strained a muscle, and one of the first things that gets blamed is the statins, even though the statins are one of the number one things that they could take to help prevent a future heart attack or a stroke down the road. So I have this conversation quite frequently. As far as when you take it, what time of the day do you take it to help prevent that from happening? I'm not sure that there's an ideal time. What I often recommend is if you're having issues with the statins and you think it might be contributing to some muscle discomfort, try to take it at night and see if that gets better, because by the time you wake up, the levels will be a little bit lower in your system. So you could try that and see if it helps.
Kind of following along that line, is there a statin that does not cause memory problems or loss?
Yeah, I think the memory loss issue with statins, again, this is going to be even less common than muscle aches, far less common than muscle aches. That's a rare side effect for all the statins out there. I would certainly not say that it's a significant enough side effect where you want to stay away from statins. Again, the benefits of these medications, in my opinion, outweigh these risks. But if you're experiencing these problems and you're on a statin medicine, you should certainly talk with your doctor about it.
Okay.
As far as which statin, I don't think there's any one statin that would be better than the other.
And you know, I have a handful of patients that they don't tolerate a certain statin, but they will tolerate another. You know, we have multiple statins, medications that are in the statin class. So sometimes it's just a matter of finding which one works best for them, and getting patients to realize that it's not all statin. You know, if you don't tolerate simvastatin, that doesn't mean every other statin is going to cause the same side effects for you as well. So,
Okay. Dr. Kryb, when you're in there doing an open heart bypass, what does the plaque actually look like? Does it ever go away?
It's hard to describe it. I guess it kind of looks like it's yellowish. Sometimes it kind of has a cotton cheese calcium component to it. It's kind of like, it looks like really hard fat that's kind of gelatinized in there. Ruptured plaque also looks like, kind of looks like a hematoma of sort. That's rough. You know, it's not really smooth per se. And they all feel very hard. You can tell exactly where the plaques are on the artery, because normal artery is pretty soft and pliable, and once it gets plaque in it, it just becomes like a pipe. Maybe kind of like a clogged up pipe that's got calcium built on it. I don't know if you guys ever have to take some pipes apart in your bathroom. Almost like that. What was the other part of the question?
Does it ever go away?
And no, it does not ever go away. The plaque is unfortunately can't disappear once you build it. And we know from studies on like soldiers that die and things like that, that most of us start forming plaque in our 20s. And it doesn't go away, so the best thing we can do is reduce the rate of and the formation of plaque. And the goal of bypass surgery, another question I get asked often is, am I going to remove the plaque? And the answer is no as well. I can't remove all of it. And so the goal of bypass surgery is actually just to build a new highway. The analogy that I use of plaque is like a pile up on the main interstate towards your heart. We can't get the tow trucks in and clean it out, but what we do is we build a new highway. So that kind of gives you a new lease on your arteries. But you still got to you still got to do all the right things, because plaque in other places is going to continue building up, and those veins, the bypasses, the same process happens there as well. And so it's important to continue with a healthy lifestyle and doing all the right things, even after you had your heart fixed.
Okay. Thank you. Corey, if you are picking up somebody that is having a heart attack, what level of care are you able to provide a patient?
Well, in Billings, we are all of the 911 ambulances that we have are paramedic level of care. So as a paramedic, when we come in, I'm going to be putting you on oxygen, starting an IV, and I'm going to be obtaining an EKG. Once I obtain an EKG, I will usually do a 12-lead EKG if I'm suspecting that there is something going on with your heart. I also then transmit that EKG with my LifePack monitor to the hospital. All of the paramedics are certified with the advanced cardiac life support. We carry a lot of the same medications that we have in the emergency departments in order to start treating you. We're going to give you aspirin, we have nitroglycerin, we have morphine. Those are the medications for a person that is conscious to be receiving. We also have quite a few for, a heart attack or sudden cardiac arrest patient that we are able to do. And not only is it the medications, but it's also obtaining that 12-lead EKG. We can put your name on that EKG, and when we transmit it to the hospital, the clerk in the emergency department is able to grab that off. The emergency room physician is notified. They're able to pull your records, pull previous 12-lead EKGs, and see if there are changes. At 1 o'clock in the morning, when we're coming to get you, if we see that something is happening on that EKG, we also do what's called a STEMI activation in the field, where we notify the hospitals that, hey, we are seeing some ST elevation on this EKG. We transmit it to them. The physician confirms that, and then they call in all of these guys. So at 1 o'clock in the morning, if you call for an ambulance, it's early notification, not just getting you to the hospital, but also getting all of the other resources to the hospital for you so that we're able to take care of you right away.
Okay. This could be for Dr. Kriev or Dr. Plank, probably. I have been told that I have reduced lung capacity. I have never smoked, but lived with smokers for most of my early life. I have been diagnosed with vocal cord dysfunction. I had a heart cath once before this diagnosis and was told my heart was okay. But am I at risk with this history? If I need to repeat, let me know.
I think the answer to that question can be relatively complex without knowing the whole history and what is this reduction in lung function is. And there's hundred diseases that can cause lung problems outside of smoking or being around smokers. And so some of that is going to be related to that. And exactly what the shortness of breath is and trying to figure out, is it the lungs, is it the heart? A lot of times, some of the times we even can't. We don't know if the patient is short of breath because their lungs are bad or because their heart is bad. And a lot of times we end up treating both, or we treat one, we'll see how they do, and then we treat the other. And so the approach is really individual. You kind of have to take it by case basis.
Okay. Great. Dr. Plank, can you speak to how stents or angioplasties are performed and if they cure coronary artery disease? And if I was smoking before I came into the cath lab, do I need to stop after?
Sure. Okay. So as far as how it's done, if you're having a heart attack, or if you're somebody that has anginal chest pain that's not adequately treated with medications, you may be referred for an angiogram. And the way that's done is you're brought into our cath lab. We have a whole team of nurses and technicians and myself and some other cardiologists that work in the cath lab. We're going to take you into the procedure suite, and we're going to give you medication that will make you very, very comfortable. You'll feel great. And once you're sedated, and I say sedated, some people think that they're going to come in and be put on a ventilator, and just like you're undergoing surgery. It's not that kind of thing. We use moderate sedation, similar to a colonoscopy, if you've ever had a colonoscopy before. Similar meds. In any case, you'll be very comfortable. We get your skin numbed up with a medication so that even if you're wide awake, it shouldn't hurt that bad. And then what we do is we use a needle to get into an artery. And we either use the big artery in the groin, or more and more now we're using the smaller artery in the wrist to do these procedures. Once we get into that artery, we put a special kind of tube called a sheath, and that's basically a big IV that stays in that artery. And we can put our catheter, which is a very long and narrow tube, all the way through that artery up to the heart. And we look at the arteries in the heart using x-rays and contrast dye, which is a liquid that shows up on the x-rays. And we're looking for blockages. If we find them, we can sometimes fix them with stents like we talked about, and that can be done right there while you're in the procedure room. If you do get a stent, the stent will push that blockage out of the way and hopefully keep that artery open, but the stent does not cure the coronary artery disease that caused it. It just pushes it out of the way. And I do remind people of that, my patients that I put stents in. You still got to quit smoking if you're a smoker. Sometimes people replace the smoking for chewing tobacco. I've busted a couple people on that before, so you got to avoid tobacco altogether. But yeah, it doesn't, stents don't cure the disease, it just opens the blockage. You got to stick with the medication program, lower the bad habits, stop smoking, eat better, exercise to help prevent another one. And then, was there another part of that question? Or is that it?
No, that you need.
That was it, okay.
Aaron, do statins help reduce inherited cholesterol? And if not, what is the course of treatment?
So statins do help in reducing genetic and inherited cholesterol. We still will sometimes struggle with getting the numbers down where we would like to see them. However, again, we have had new guidelines that just came out this year regarding statin use and cholesterol numbers, and they're recommending not focusing on the numbers as much as focusing on risk factors and which potency of statins you should be on. So there's going to be a little bit of a shift you may hear from your providers with a little bit less focus on the numbers. So, genetics are, as I tell all my patients, that's the one thing that's difficult because we can't control that. We can't control who your parents were and what they had affect them. And I think that's the hardest thing for younger patients when they're started on statins because they are younger. I have some that I'm young, I'm active, I eat right, I don't smoke. I'm doing everything you're telling me to do, but you come in and tell me my cholesterol's too high and that I need to be on this medication. The statin does help that, just sometimes not as much as patients would like with numbers.
Okay. Dr. Kryev, can you get a heart transplant here?
Not in Billings. We don't have a transplant center. It's a long and big process to get a heart transplant. The closest places would be Salt Lake, Denver, Mayo, or Seattle, or Portland. Yeah.
Oh, question.
I will add to that, though, that we do work with a group out of Utah, out of Salt Lake, where they do heart transplants and also put in LVADs. And they actually come up about once a month, once every other month to see patients here locally, which helps because they help evaluate, if you meet criteria for a transplant or an assistive device, and helps decrease the travel time. You would still have to go there for the transplant, but it helps reduce travel for the multiple appointments that you would need to do beforehand.
And an LVAD is an artificial heart.
Dr. Kryev, can you discuss more about bypasses?
I think we talked about some of that, but I guess, back to that analogy, the plaque that builds up inside the coronary arteries it's a pipe that gets plugged up, and so the blood supply and oxygen supply to the heart is diminished, and so as the heart tries to work harder and stronger, it can't do that because it's not getting all the nutrients that it needs. And the goal of the bypass operation is to build a new pipe, build a new highway, and we use the roadmap that's created during the cardiac catheterization that Dr. Plank can give us pretty great pictures that shows exactly where the worst plaque is or which parts of the arteries are still not covered with plaque. And then based on that, we'll plan on where to bypass and how. Again, everybody's case is different and individual. It goes by make those decisions patient at a time. There's not really a rule that applies to everybody. And the operation itself is, for the most part, we can't work on the engine while it's running. And there are some ways to work on the engine when it's running to do the bypass operation, but some of those we really can't. And so we use the heart-lung machine to help us, and the heart-lung machine kind of takes the function of the heart and the lungs while we're working on the heart. And we use arteries or veins to kind of build those new pipes, those new highways. And once we're able to plug them in onto the heart, kind of where the good spots are, or where, where it gets past the plaque and past the pileup in the highway. And then the other end of it gets plugged in the aorta and the main blood vessel that comes right out of the heart. So we know the blood supply there is going to be great. Then we just got to close up and put everything back together. So.
All right. Well, at this time, I would like to welcome Phil Ehlers, and if I said your last name wrong, I apologize. He's a paramedic from Shepherd who is a survivor of a heart attack and has a very interesting story to share with us. Thank you, Megan.
My name is Phil Ehlers. I'm the chief for Shepherd Fire. I am not a paramedic. I'm an EMT. I have been part of 5 successful CPRs. I am their nightmare. I had indigestion. I took Tums. I was getting relief. I was burping. I stopped by the hospital, was going to get some industrial strength antacid. Next thing I know, they gave me a heart attack. Where you hear about the signs and symptoms, and as an EMT, I literally looked myself in the mirror in my bathroom. Do you have this? Do you have this? Do you have this? Do you have this? And it was no, 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 no. And it wasn't denial. I did not have anything other than the indigestion. I went into the ER, walked in, drove myself to the hospital, walked myself into the ER. The nurse at the admitting desk said, "What's your problem?" I said, "I've just got this indigestion. I want some industrial antacid." He goes, "We got to do a 12-lead EKG on you, or a 4-lead EKG, excuse me." And I said, "Okay, I'll play your game." I walked in. He pulled out a wheelchair. I said, "Who's that for?" And he goes, "That's for you." I said, "You want to bet?" I went over and hit the button, walked in the back. I said, "What room are we going to?" "Room 4. Again, I'm an EMT. I'm kind of familiar with the ER. We ride in with AMR doing CPR in the back of their ambulances. I went in there. They put the gown on. They put the 4-lead on. A nurse looked at it and said, "We better put a 12-lead on." Son of a... As soon as they said that, I knew something was going on. I walked in at 8 o'clock, 8:15, I was headed to the cath lab. Don't hesitate to call. Don't hesitate to call. I have used this to my advantage. I had a stent put in. Dr. Ra was my physician. I remember he walked into the ER, and he said, "Today's your lucky day." I said, "Excuse me?" They say I'm having a heart attack? He said, "Well, I'm Dr. Ra, and if you let me finish my breakfast," he had a half-eaten bagel with strawberry cream cheese. It's amazing the things you remember. Once I'll get you up to the cath lab. Normally he goes, "I was on call yesterday, so I'm coming in late. Otherwise, I would have patients." I went, "So, okay, do whatever." And while he was doing the procedure, placed the stent. "So how's your pain?" "What pain?" "The pain you were having." "I wasn't having any pain." "Oh yeah, you weren't." "No, I wasn't. I had no pain. I was not a typical heart attack." I get to my room in the ICU. They gave me my phone. I was getting all kinds of calls, especially from people in the department. And it was one of 2 questions. "How you doing?" or "Are you an idiot for driving yourself in?" Okay? So basically, like I said, I've used the heart attack to my advantage. I carry a bottle of nitro, never had to use it. However, I have used it on several patients. We're all tough, we're all Montanans, we're all, okay? I'm a retired Marine. Yeah, 10 feet tall and bulletproof, okay? I'm not having a heart attack. So when you're getting that, we had a couple of patients, "I'm not having anything." I just leaned in real close, pulled the nitro out of my pocket, and "See this?" And he goes, "What is it?" I said, "It's nitroglycerin." "Well, that's what you guys," I said, "No, this is mine. This was issued to me. This is for my heart condition." Maybe I will go in with the ambulance. I think you were, one of the calls you were on that one of those. And they were bound to determine, oh, my wife will drive. I says, no. So I've used it to my advantage. I'm healthy. I'm a bricklayer. I was a bricklayer before, retired Marine. I'm not a couch potato. If your heart says, if something's going wrong, call 911. A lot of people, especially, I won't say, the more seasoned people, I don't want to be an inconvenience to anybody, especially at 2 in the morning. I don't want to be an inconvenience to somebody. I tell you what, I would rather come out there and in the Shepherd area, you'll get my smiling face before you'll get her smiling face. We respond every time. We don't transport. So every time we get out there, AMR's backing us up. We give aspirin, nitro. We do some interventions before they get there. They've got the 12 lead. We don't have a 12 lead because we don't transport. Okay? Call 911. I'd rather be working on you when you're upright and talking to me than on the ground and me breaking your ribs doing compressions. I'd rather see you that way than the other way.